last class I have sent you a video on penis. So I hope you have seen the video, and please go through Robbins. Okay. So male genital tract, consists of the penis, testis and epididymis, and prostate. Okay. So for today's class, I'll take on testis and epididymis. Now, you know that the normal human adult, okay, male, they have a paired organ, okay, they have a paired organ which lies within the scrotum, and it is hanged through the spermatic cord. All right. So this is a picture of the testis. All right. This is a picture of the testis, and you can see it is connected to the epididymis through the red testis. Okay. Then from the epididymis, it goes and is continuous with the vas deferens. All right. So in the testis, there are about 250 lobules. Okay. So these are each lobule. So each of these lobule consists up to 4 seminiferous tubules. All right. So the sperms which are produced here, they go through the red testis. They get mature here in the epididymis, and they pass through the vas deferens into the ejaculatory ducts. Okay. So this testis, it is covered by a capsule, okay, which consists of 3 layers. The outermost layer is called the tunica vaginalis, okay, and this tunica vaginalis is covered by a flattened layer of mesothelial cells. All right. Below that tunica vaginalis is the tunica albuginea. All right. And below the tunica albuginea is the tunica vasculosa. All right. Now, like I told you, like there are about 250 lobules, inside the testis, and each of the lobules have up to 4 seminiferous tubules. So this is a picture of these seminiferous tubules. Okay, so this is one seminiferous tubule, this is another, and in between these seminiferous tubules, there are some stromal cells and some Leydig cells. Okay. Now inside this seminiferous tubules, you'll see these are the germ cells. All right. Inside the seminiferous tubules, there are germ cells, and there are also some cells called Sertoli cells. Okay. Sertoli cells, these are the nurse cell, and they help in the process called spermatogenesis. Okay. So if you see this picture, so just imagine this is the seminiferous tubules, which is limited by a membrane. Okay. So just imagine this is the membrane. So the cells, like first of all, the germ cells, okay, they are called spermatogonium. First there is a type A, and then they mature into type B. Okay. Then it goes into primary spermatocyte, then secondary spermatocytes, then spermatids. All right. So it goes from here, from this membrane, it goes downwards. Okay. So this process of maturation from spermatogonium till the time they form a mature sperm, okay, that takes about 70 days in a human being. Okay. And so you can see these are the germ cell, and inside in the lumen you can see there are some mature sperms. All right. Now, sometimes this testis is not always seen in the scrotum at birth. Okay. Now, why does this happen? Now, testicular descent can occur in 2 morphologically and hormonally distinct phases. Okay. One is the transabdominal phase. This transabdominal phase is controlled by this Mullerian inhibiting substance. All right. And here the testes lie in the lower abdomen or in the brim of the pelvis. All right. Then in the inguinal-scrotal phase, which is androgen dependent, here the testes descend through the inguinal canal into the scrotal sac. Okay. So this testicular arrest, it can occur anywhere along this pathway. Okay. But the most common arrest happens in the inguinal canal. Okay. So this can cause, it can be accompanied with inguinal hernia, can cause injury also. Okay. So coming to the congenital anomalies in testis, they are kind of rare. Okay. Like sometimes there is complete absence, or maybe only one testis is present. Okay. And sometimes both the testes are fused together. That is called synorchism. Okay. To another term, it's called cryptorchidism. This is a complete or partial failure of the intra-abdominal testis to descend into the scrotal sac, and is associated with testicular dysfunction and an increased risk of testicular cancer. Okay, now this happens in 1% of 1-year-old boys. It is unilateral in most of the cases. It's unilateral, okay, and bilateral in about 25% of the cases. Okay, cryptorchidism is usually asymptomatic, and usually the patient discovers it only when they palpate the scrotal sac and find it empty. Okay. So histologic changes in the undescended testes, they begin as early as 2 years of age. Okay. So what happens inside the seminiferous tubules? There is arrested germ cell development, okay, associated with marked hyalinization and thickening of the basement membrane of the spermatid tubules. Okay, that means that process I told you, that spermatogenesis, where sperms are formed, that process is arrested. Okay. So the tubules become atrophied. So you can see in this picture, this is a normal seminiferous tubule, and you can see these germ cells, they mature and finally form the sperms. Okay, but in case of a patient with cryptorchidism, there is testicular atrophy. Okay, you can see that these seminiferous tubules, they become thickened. Okay, the basement membrane become thickened, and there are no germ cell inside. These are only Sertoli cells. Okay, and because the stromal cells are increased, so that's why even the Leydig cell appears to increase. Okay, so this is a case of testicular atrophy in case of cryptorchidism. All right. Now, when the testis lies in the inguinal canal, usually it is prone to trauma. It is prone to crushing injuries. Okay, and it's also accompanied with inguinal hernia. All right, in some cases. So this undescended testis, as I told you, it has a greater risk of developing testicular cancer than the one which is already descended. Okay, so usually you have to wait for 1 year. Okay, like if you find a child who has cryptorchidism, you have to wait 1 year for it to. Sometimes it takes 1 year for the testis to finally descend spontaneously. Okay, but in some case, but you can't wait beyond 2 years, because if you wait till 2 years, then there will be histologic change, okay, after 2 years. So that's why surgery should be performed after the child is 1 year, but less than 2 years. Okay, and what surgery we do is we do orchiopexy. Okay, this is placement of that undescended testis into the scrotal sac. All right. Now coming to atrophy and decreased fertility. So what is testicular atrophy? I've shown you the picture of that testicular atrophy. So testicular atrophy, it has many causes. Okay, it can be caused by so many conditions. One of them, like especially in old age, it can be because of progressive atherosclerotic narrowing of the blood supply. Okay, it can be the end stage of an inflammatory orchitis. Okay, it can be like cryptorchidism. Then it can be hypopituitarism, generalized malnutrition, irradiation, or prolonged administration of anti-androgen. Okay, so these are some of the causes of atrophy and also decreased fertility in a male person. Okay. Now coming to inflammation. So inflammation of the epididymis is called epididymitis. Okay, inflammation of the testis is called orchitis. Okay. Inflammation is usually more common in epididymis than in testis. Okay, in testis, tumors are more common. All right. Now coming to the specific inflammation. So specific inflammation can be because of gonorrhea, tuberculosis, syphilis, or mumps virus. All right. So this gonorrhea and tuberculosis, they usually affect the epididymis first. Okay. Syphilis usually affects the testis first. All right. Now, mumps virus, you know, mumps is like a systemic disease. Okay, it can affect school age children, and it can cause parotid gland swelling. All right. But in these school age children, testicular involvement is very uncommon. All right. Whereas in post-pubertal males, orchitis, that means involvement of the testis, okay, is seen in about 20 to 30% of these people infected with mumps virus. All right. Now coming to non-specific inflammation. Now epididymitis and possible subsequent orchitis, they are commonly related to infection in the urinary tract, like cystitis, inflammation of the bladder, inflammation of the urethra, inflammation of the prostate. Infection from here can go and infect, you know, the epididymis, and then subsequently it can affect the testis too. Okay, so epididymitis in childhood is usually associated with a congenital genitourinary abnormality, and infection with gram-negative rods. Okay, in men who are younger than age and who are sexually active, the sexually transmitted pathogens like chlamydia trachomatis and Neisseria gonorrhea are the most frequent culprits. Okay, whereas in men older than 35 years, the common urinary tract pathogens are like E. coli and Pseudomonas. All right. So in any case of acute inflammation, what will be there? There will be infiltration by neutrophils. Okay. So what you will see in acute epididymitis, there will be congestion, edema, infiltration by neutrophils, macrophage, sometimes lymphocytes. Okay. So in the early stage, it will only involve the interstitial connective tissue. Okay, so interstitium is that area between the seminiferous tubules, okay, where the Leydig cells are there. So those are the area where the infection will start. Okay, so sometimes when the infection stays, it can extend and involve the seminiferous tubules too. Okay, and this might progress to abscess formation or complete suppurative necrosis of the entire epididymis. Okay, so you can see in this picture, this is a epididymis which is completely replaced by an abscess, and this is a part of a normal testis. Okay. Now coming to the vascular disorders in a testis. Now there is a term called torsion. Okay, so what happens in torsion? There is twisting of the testis. Okay, when the testis twists, what happens? It blocks the venous drainage. Okay, because of the blockage of the venous drainage, the arteries, okay, the thick wall arteries, they are still patent, so they become completely congested. Okay, and there will be if it is not corrected, it can go into a hemorrhagic infarct. Okay, so this torsion, it can happen during neonates. Okay, it's called neonatal torsion, or it can happen in adults, like especially the young men, okay, adolescent men, and this is a very painful condition. Okay, and it is one of the urological emergency. Okay, because if you don't untwist it within 6 hours, then the testis becomes totally aviable. Okay, it'll become necrotic. That's why you need to untwist it within 6 hours. Okay, after the torsion happens. Now coming to testicular tumors. Okay, there are two major categories, okay, of testicular tumors. The first one are the germ cell tumors, which comprise about 95%. Then we have the sex cord stromal tumors, okay, and also some other tumors like lymphoma. All right. So these germ cell tumors comprised about 95%, and they are divided into the seminomatous tumors and the non-seminomatous tumors. Okay. So under the seminomatous tumors, you have seminoma, spermatocytic seminoma. Then under the non-seminomatous tumors, you have embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratomas. Okay, then sex cord stromal tumors are like Leydig cell tumor, Sertoli cell tumor, then granulosa cell tumor. Okay, so what is the pathogenesis of these germ cell tumors? Now, it is believed to have a environmental influence. Okay, so what happens? There was a study done on the people from Finland. Okay, so usually people from Finland have a lower chance of getting testicular germ cell tumors than those people from Sweden. Okay, but when these people from Finland, they migrated to Sweden, okay, it was found that the incidence of these testicular germ cell is very similar to the people of Sweden. Okay, so that's why it was thought to have an environmental factor. Okay, then also these testicular germ cell tumors, they are associated with a spectrum of disorders which is known as testicular dysgenesis syndrome. Okay, now component of this syndrome, it includes like cryptorchidism, hypospadias, and poor sperm quality. Okay, and it has been proposed that these conditions are increased by in utero exposure to pesticides and non-steroidal estrogen. Okay, it is also found in the United States that the white people are affected much more common than the black people. Okay, in a ratio of 5:1. All right. Now coming to genetic factors, the relative risk of these tumors is 4 times higher than normal in fathers and sons of affected patients, and is 8 to 10 times higher in brothers. Okay, so that means the first degree relative has a higher risk of getting these tumors. Okay. Now, most of the testicular germ cell tumors, they originate from a precursor lesion called intratubular germ cell neoplasia. Okay, exceptions are there, like for example, these pediatric yolk sac tumor, teratomas, and spermatocytic seminoma, they do not originate from this. Okay, now this intratubular germ cell neoplasia is usually present in utero. Okay, and it becomes dormant. Okay, it becomes dormant till about puberty, and after puberty it can be converted into a seminomatous or a non-seminomatous tumor. All right. Now coming to the first germ cell tumor called seminoma. Okay, so what is this seminoma? This is the most common type of germ cell tumors, and it comprises about 50%. Okay, now usually it affects the third decade of life. Okay, but it never occurs in infants. All right. Now a similar tumor is found in the females. It is called dysgerminoma. Okay, so you should remember, if a similar tumor involves the testis, this is called seminoma, and that which involves the ovary, it is called dysgerminoma. Okay, so these tumors, they express, okay, some of these genes called OCT34 and NANOC. Okay, and 25% of them have this KIT activating mutation. So when you do an immunohistochemistry, okay, when you do the stain, they will be positive for KIT, for OCT4, and also for PLAP. Okay, this PLAP is placental alkaline phosphatase. Okay, so these are the specific markers for seminoma. Okay, now what do you see grossly? You will see in this picture. Okay, you can see that the testis, a cut section of the testis shows a well circumscribed pale, okay, fleshy, homogeneous gray white tumor, okay, which is usually devoid of hemorrhage or necrosis. Okay, so if you see hemorrhage and necrosis, that means it might be a mixed germ cell tumors. Okay, it might not only be a seminoma component. Okay, now coming to the histology, okay, of a seminoma. Now these seminoma, if not otherwise specified, okay, they are referred to as typical or classic seminoma. Okay, they are arranged, as you can see in this picture, they are arranged as sheets of cells which are uniform. Okay, and they are divided into polyform lobules by these fibrous strands. Okay, now these fibrous strands, they have lymphocytic infiltration in them. Okay, now if you can see in the next picture, which is a higher power, you can see that these cells, they are large and round to polyhedral. Okay, you can see they are large and round and polyhedral. They have a distinct cell membrane. Okay, that means this membrane is very distinct, their cytoplasmic membrane, and their cytoplasm is clear, watery. Okay, and they have a large central nucleus with one or two prominent nucleoli. Okay, and you can see these lymphocytes infiltrations in between. Okay, then there is another term called anaplastic seminoma. Okay, so this anaplastic seminoma, it shows anaplastic features, okay, including frequent tumor giant cells and a greater number of mitosis. Okay, so this anaplastic seminoma and typical melanoma, usually they don't have a difference in their prognosis. Okay, now coming to another germ cell tumor called spermatocytic seminoma. Okay, these are rare tumors. They are slow growing. Okay, and they usually affect the older men. Okay, more than 65 years. Okay, so even though their name is very similar to a seminoma, okay, but these spermatocytic seminoma are very distinctive tumors. Okay, they have a gross features of soft pale gray, okay, cut surface that sometimes reveal mucoid cyst. All right, and microscopically you will see there are 3 types of cells which are all intermixed, like small, intermediate, and large cells. And unlike seminoma, which has lymphocytic infiltration in the fibrous strand, these spermatocytic seminoma, they do not have any lymphocytes. Okay, now coming to embryonal carcinoma, these are non-seminomatous tumors. Okay, so these are very aggressive tumors, and they usually involve males who are in the age group of 20 to 30 years. Okay, they have a variegated appearance. Variegated means heterogeneous. Okay, and with areas of hemorrhage and necrosis. right? Now markers, like for IHC markers for this embryonal carcinoma, like OCT34, PLAP, they are also positive. Like seminoma, I told you OCT34 and PLAP are positive in seminoma, okay? But in case of embryonal carcinoma, they are also positive for CD30, CK, cytokeratin, okay? And they are negative for KIT, okay? You know that seminoma, it is positive for KIT and they are negative for CD30, okay? So this is how you can differentiate, okay, between the two. Then histologically, these embryonal carcinoma, they are arranged in an alveolar or tubular pattern, okay, with papillary convolution, and the undifferentiated areas shows only sheets of cells, okay. Mitosis is very frequent, and you can see here, these are some sheets of undifferentiated cells. They have anaplastic features, okay, like they are large, they are hyperchromatic, okay, and this is a area showing a primitive glandular element, okay. So this is a histological picture of embryonal carcinoma. Now coming to yolk sac tumor. Okay, yolk sac tumor is also known as endodermal sinus tumor. This is the most common testicular tumor in infants and children up to 3 years of age. Okay, and it has a very good prognosis in these children. Okay, but in adults, it usually occurs in combination with other germ cell tumors. Okay, it is a mixed germ cell tumors in adults. It doesn't occur in its pure form. All right. Now in yolk sac tumor, what do we see? There is an elevated AFP, okay, alpha fetoprotein level. Okay, so grossly, it's usually a non-encapsulated and have a homogeneous yellow-white mucinous appearance. Okay. Now yolk sac tumors, you can see here in this picture, they are arranged. The cells are like having a lace-like or reticular network of these medium-sized cuboidal or flattened cells. Okay, and they have a very characteristic feature which is called a Schiller-Duval body. Yes, so this picture, this is a Schiller-Duval body. It has a central capillary, okay, and it's surrounded by a visceral and a parietal layers of cell. Okay, so this resembles a primitive glomeruli, like in the kidney, the primitive glomeruli. So this is called a Schiller-Duval body, and it's seen in almost 50% of these yolk sac tumor. Okay, now also seen are these pinkish eosinophilic material within the cytoplasm or outside the cytoplasm. These are called hyaline-like globules. Okay, and these hyaline-like globules, they contain this alpha fetoprotein, okay, AFP. So that's why in yolk sac tumor, you'll see that the AFP level is very high. Right. Now coming to choriocarcinoma, this choriocarcinoma is a very highly aggressive tumor, right? And usually it does not present with testicular enlargement. Only sometimes it presents as a small palpable nodule. Okay. Now what does it composed of? It composed of these syncytotrophoblasts. Okay. These are multinucleated cells, okay, which has an abundant eosinophilic cytoplasm, and inside the cytoplasm it contains HCG, okay, this beta HCG. So that's why in case of choriocarcinoma, you'll see a very high level of this HCG. Okay, then you can see other cells like the cytotrophoblasts. Okay, these cytotrophoblasts are more uniform. Okay, they're more round and they occur in cords or groups. Okay, like this, and in background has a lot of necrosis. Okay, so this choriocarcinoma, if in its pure form, it is very rare. Okay, it's like about 1%. Okay, but usually it occurs as a mixed tumors with other germ cell tumors. Right. Now coming to teratoma. Teratoma arises from 2 or more than 2 germ cell layers. Okay, so what are those germ cell layers? We have ectoderm, endoderm, mesoderm. Okay, so ectoderm are like skin, mucous membrane, sweat and sebaceous gland, hair, tooth, neural tissue like brain and nerve. Okay, endoderm are like epithelial lining of different organs like respiratory epithelium, thyroid and parathyroid glands. Mesoderm like cartilage, bone, adipose tissue, muscle, blood vessel, lymphatics. Okay, so this teratoma can occur at any age. Okay, so that's why grossly, because it has heterogeneous material, like sometimes it has both the ectoderm and endoderm. So that's why some area might be cystic, some area might be solid. Okay, now teratomas, the elements may be mature, okay, when they resemble the adult tissue, or they might be immature when they resemble the fetal or embryonal tissue. Okay, so there is a term called teratoma with malignant transformation. Here what happens, a malignant this happens very rarely, okay, and there is a malignant non-germ cell tumor arising in teratomas, okay. Now, for example, as you can see in this picture, this is a teratoma showing a cartilage, okay. These are cartilage, these are glands, some are like intestinal epithelium, okay. Here also you can see these are cartilage, some glands, some muscle, okay. So there is a different components, all right. And usually in a child, this differentiated mature teratomas are benign course, okay. But remember, in this teratoma can happen in the ovary too, okay. So in a female, in the ovary teratomas, you have mature and immature, right? And mature are usually the benign and immature are the malignant. But in case of testicular teratoma, okay, in post-pubertal male, all these teratoma, whether they are mature or immature, they are regarded as malignant, okay, and they are capable of metastatic behavior. All right. Now coming to mixed tumors, okay, about 60% of these testicular tumors, they composed of more than one pure pattern, okay. So the most frequent combination are like, you will find a teratoma with embryonal carcinoma and yolk sac tumor. Sometimes you can see seminoma with embryonal carcinoma, sometimes embryonal carcinoma with a teratoma, also known as teratocarcinoma. So there are various other combinations, okay, which happens in a mixed germ cell tumors. Now coming to the clinical features of testicular germ cell tumors, they are usually painless, okay, painless, and they just present as like an enlargement of the testis, okay. Now lymphatic spread is the most common way of spreading, okay, in these tumors, and it spreads first to the retroperitoneal para-aortic nodes, and then after this it goes to other like mediastinal or supraclavicular node, right? Then hematogenous spread is primarily to the lungs, okay. Other organ which can be involved are like liver, brain and bones, okay, but first they usually spread to the lungs, okay. Now, what is the difference between a seminomatous and a non-seminomatous germ cell tumors? Okay. Now you can see seminomas, they tend to remain localized. Okay, they are localized to the testis for a long time, and so about 70% of them, they are in clinical stage 1. Okay, whereas in contrast to that, about 60% of male with non-seminomatous germ cell tumors, they present in the advanced clinical stage like stage 2 and stage 3. Okay, now metastasis from seminoma, they usually involve lymph nodes. Okay, they have usually there is a lymphatic spread. Hematogenous spread usually occur much later in the course. Okay, but these non-seminomatous germ cell tumors, they not only metastasize early, but they also use the hematogenous route more frequently than the lymphatic. Okay, now the rare pure choriocarcinoma is the most aggressive non-seminomatous germ cell tumors. Okay, it may not cause any testicular enlargement. Sometimes I told you that choriocarcinoma, they present just as a small palpable nodule. So these choriocarcinoma, they can just spread, like rapidly by bloodstream. Therefore, by the time you diagnose it, there is already spread into the lungs and liver. Okay. Now coming to the clinical stage. Okay, what are the clinical stage of these germ cells? Stage 1 is when the tumor is confined to the testis, epididymis, and spermatic cord. Okay. Now stage 2 is when there is distant spread confined to the retroperitoneal nodes, but below the diaphragm. Okay, below the diaphragm is stage 2. Whereas stage 3 is metastasis outside these retroperitoneal nodes or above the diaphragm. Okay, so these are the clinical stage of testicular tumors. Okay, now the therapy and prognosis of testicular tumors will depend on this clinical stage and also on the histologic type. Okay, now for example, seminoma, which is radiosensitive and tends to remain localized for a long period, they have the best prognosis. Okay, now approximately 90% of patients with non-seminomatous germ cell tumors, they can also achieve complete remission with aggressive chemotherapy, and most of them can also be cured. Okay, now coming to the sex cord stromal tumors, just in brief. Okay, now sex cord stromal tumors, I told you, like Leydig cell tumor. No, Leydig cell are those cells which are present in the interstitium in between the seminiferous tubules. Okay, so these tumors are usually benign. Okay, and they are hormonally active. That means they secrete hormones like androgen, estrogen, sometimes even corticosteroids. Okay, so because they secrete estrogen, okay, so other than presenting as a testicular mass, a person can also present with gynecomastia. Okay, gynecomastia means enlargement of the breast in a male patient. Okay, so these can present as gynecomastia. All right. Then we have Sertoli cell tumors. These are also known as androblastoma. They are usually benign, but about in 10% of the cases they can be malignant. Okay. Now these tumor cells, they are arranged in distinctive trabeculae that tend to form cord-like structure and tubules. Okay. Now coming to other types of tumors seen in the testis, this is testicular lymphoma, mostly non-Hodgkin lymphoma, and this is seen. This is the most common form of testicular neoplasm in men older than the age of 60 years. Okay. Then coming to hydrocele. Now, like I told you that the testis is surrounded by a capsule, right? So the outermost capsule is the tunica vaginalis, which is lined by mesothelial cell. Okay, so when the serous fluid accumulates, okay, in this tunica vaginalis, that is called hydrocele. Okay, hydrocele means, and this will cause a considerable enlargement of the scrotal sac. So this is a picture of hydrocele. Then other terms which you should know are like hematocele. Okay, hematocele means presence of blood in the tunica vaginalis. Okay, chylocele, this is usually as a result of trauma. Okay, and sometimes because of torsion also you can have a hematocele. Then we have chylocele is accumulation of lymph. Okay, like in a person who's infected with filaria like elephantiasis, okay, there is obstruction of the lymph, no? The lymphatics. So as a result, lymph gets collected in this tunica vaginalis, and this is called chylocele. Okay. Then we have spermatocele. What is the spermatocele? This is a small cystic accumulation of semen in the dilated efferent ducts or ducts of the red testis. Okay. Then another term you should know is called varicocele. Varicocele is usually a dilated vein seen in the spermatic cord. Okay, and this is one of the cause of infertility in an adult male. Okay, so these are some of the things you should know, okay, on testis and epididymis. So you go through again Robbins, okay, the chapter testis and epididymis, and on my next class I will take on prostate. Okay, so